So in the next few minutes, I will be talking about comprehensive models of care for NAFLD, and this will inform our discussion following this presentation. Although NAFLD is prevalent in 25% of the general adult population, there is a huge disparity between this estimated prevalence and the actual diagnosis and recording in primary care. This comes from 4 large GP databases in 4 European countries. And as you can see, the coding of NAFLD starts from as low as 0.2%, and the highest percentage is 2.6%. So there is a lot to be achieved still in recognizing the disease. Then this comes from Jeff Lazarus. It reviewed the NAFLD policy in 102 countries around the world, and it calculated a preparedness index based on the availability of national NAFLD policies, guidelines, civil awareness, epidemiology and data, NAFLD detection, and NAFLD management. And the results were very, very discouraging. The highest achieved score was just 42%, and a third of the countries scored 0. The part of the problem is that there are no formal screening strategies for NAFLD, and the diagnosis is still incidental, based on findings of steatosis on ultrasound or of findings of abnormal liver blood tests performed for another region. And the referral to liver specialists are not standardized and are very variable. And even the assessment of NAFLD varies a lot. This is from UK data, but they still apply today. And you can see, for instance, that in primary care, only a small minority performs the FIB-4 score. No one does fibroscans, and you can see that AST is routinely performed in just a third of the cases. There are a lot of challenges that include low awareness, variability in clinical care. The guidelines that are produced by hepatologists are only visible in the hepatology community, and comprehensive care models are lacking. This was an exercise led by Jeff Lazarus on how comprehensive NAFLD care models should look like. And there were 4 key questions that were asked. What services are provided? Where are the services provided? Who is providing the services? And how are the services integrated? There was a systematic review, and there were some key recommendations, 8 key recommendations that we can further talk about. Regarding what, the recommendations are to develop guidance on screening and testing with non-invasive tests, to establish patient-centered pathways tailored to the disease stage, to outline actions to prevent disease progression, and to develop guidance on treatment strategies related to disease stage. Regarding where, this would be to articulate the roles of and interactions between primary, secondary, and tertiary care providers, and establish where the co-location of services for the treatment of NAFLD and common comorbidities is feasible. Regarding the who, to define the composition and structure of the multidisciplinary team responsible for managing patients with NAFLD. And regarding how, to establish systems for coordinating and integrating care across the healthcare system. I will show you just a brief example of how we are doing this in London. And this is the Camden and Islington pathway. That is a referral pathway from primary to secondary care that consists of risk stratification at the primary care level with non-invasive fibrosis test, and then detailed instructions on how to manage disease in primary care and who to refer to specialists, to liver specialists. And you can see that by systemically using this pathway, we increase the detection of advanced fibrosis fourfold. And then regarding where and how to treat, you can see that we have a multidisciplinary NAFLD clinic that consists of a liver dietitian, a chemical pathologist for the cardiovascular risk, a specialist nurse, and then same-day non-invasive fibrosis assessment. And by having this multidisciplinary clinic on top of treatment for the liver comorbidities, there is additional treatment in 40% of the patients for their metabolic comorbidities. And this results not only in improvement of clinical liver outcomes, but also of an improvement in cardiovascular outcomes. And you can see indicatively that there is a mean Q-risk 3 score reduction of 3.4% and a mean gain of 6.1 heart attack and stroke-free years. In conclusion, and as a starting point for our discussion, NAFLD is under-recognized in the wider medical field outside of pathology. Comprehensive care models are essential. Effective pathways need to be co-designed with primary care. And finally, these care models should be multi-morbidity, patient-centered care models. Thank you very much, and we will move now to the discussion.